Hello, everyone, and thank you for joining us for today's training, the last presentation in our five-part series on a transdisciplinary approach to behavioral health populations in primary care. My name is Rick Brown, and I am the Senior Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training, and if you have any technical issues during today's webinar, please don't hesitate to reach out to me or to my colleague Joshua for help. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust, multifaceted workforce to help transform communities to advance access to quality care for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop the healthcare workforce caring for America's underserved communities. We invite you to learn more about us at acatclinicians.org. If you're interested in more resources on behavioral health for community health centers and other institutions caring for medically underserved communities, we also encourage you to visit our behavioral health program page. There you can find archived presentations, upcoming webinars and events, and more. Speaking of one of those events, we are really excited to announce that scholarships are now available to help you provide free registration for behavioral health professionals to attend our upcoming 2026 conference and our Behavioral Health Leadership Forum. Regarding the forum, taking place on July 29th in DC following our conference, this full-day symposium will feature CE/CME accredited workshops, discussions, networking, and much more on best practices in behavioral health for clinicians and leaders at CHCs. It's always a highlight of our year, and if you're interested in a scholarship, we encourage you to apply as soon as possible. This opportunity is first come, first served. You can find the link to this in the chat, and thank you so much for putting that in there, Josh. Also, before we begin, I just want to go over a few quick housekeeping items. First, we will be recording this session, and we'll share the recording and the slides with your team following the webinar. We also encourage you to ask questions via the chat during the presentation, and we'll also have a dedicated Q&A at the end of the session. Please also complete our evaluation at the conclusion of the training. It's tremendously useful to help us continue to improve the quality of our trainings. Lastly, we're also very grateful to the Centene Corporation for making this ACU-led webinar possible. Lastly, I am honored to introduce today's speaker. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of our advisory council. She is a national expert in suicide prevention and collaborative care, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior VP for a large FQHC network in New York. We're honored to have her with us presenting today, and with that, I will turn it over to her to kick us off.
Great. Thank you, everyone. And as always, thank you, Rick. You have such a wonderful voice for doing this work. It's always wonderful to listen to you kick us off. So thank you, everyone, for joining us today in our final webinar of the series. Today, we're really going to be focusing on patients with serious mental health conditions that present in our care. So we're going to talk a little bit about some special considerations. We're going to talk about what conditions might fall into this category. We're going to talk about some evidence-based practices, and we're going to talk a little bit about some billing and coding, although less of a sort of a concern for many of you with this population, but certainly we're going to talk about some of those. So for those of you who have joined us before, this is not an unfamiliar slide to you. For those of you that are new, I'm just going to go over it quickly. We have spent some time talking about your entire behavioral health population in primary care, and really thinking about how do we serve each of those populations. And so we started with health-focused interventions. We talked about the health and behavior codes, or affectionately known as the HBAI codes that are listed here, the 9-6 series. We talked about some ways to know we're successful, like CDC Healthy Days or the CDC medication adherence. And we talked about some patients that might go in that bucket, right? We talked about your smoking, obesity, some others. We talked about measurement-based care or collaborative care, because really we always want to know we're successful, and if we can measure it, we should. So we talked about using those dedicated CPT codes for collaborative care. We talked about all of the diagnoses that could fall in collaborative care. So, depression, anxiety, trauma with the PCL, bipolar with the PMQ and the PHQ, substance use with the BAM, adult and child ADHD with the ASRS and the Vanderbilt. So, tools there that we're able to measure outcomes, those can go in the measure-based care. We talked about some focus brief interventions, the population. We talked a lot about early childhood. A lot of people had asked about early childhood. That is certainly a category here. A lot of the family or group work that we do, people that have or diagnoses that we're not able to measure. So, what are some of the things? These are the life stressors, some of the non-acute services that we provide. So, that's a fairly large bucket. And we talked about what codes we would be able to use there. And then today we're going to talk about some complex behavioral health needs that are falling on the right-hand side of this grid. And then, of course, our umbrella that goes over this grid is transdisciplinary care. And transdisciplinary care has a couple of core components. And it's kind of like we have learned what makes teams successful and what good care should look like in team-based care. And a lot of you might be familiar with the terms like interdisciplinary, multidisciplinary. So transdisciplinary is kind of the gold standard past. And how does it differentiate from some of those other models? First, there is some shared training, cross training. So what are some pieces that we all need to know on the team? And then also, if I'm a behavioral health provider, I know about diabetes, right? I know a little bit more about caring for someone with diabetes. Primary care providers are going to be familiar with behavioral health care and with some of those practices. We're going to have shared care plans. It's not going to be a treatment plan and a care plan. We're going to come together and we're going to have some shared plans. And then there's going to be some accountability and some shared accountability. I am just responsible for my patients getting their PAPs and their flu shots as primary care. And then they are as responsible for some of my measures to make sure that people have a safety plan, as an example. So this is a really good way to think about your entire behavioral health population and be able to carve it out. What codes can we use? What can we do? How do we know we're successful? Who can provide those services? And it's also a really nice way to show others about the services that you provide, your behavioral health services. So we're going to talk a little bit about our serious mental health diagnoses or conditions. We're going to be talking about folks that are kind of on the acute side. So folks that might present with some psychosis or some psychotic disorders. I remember being in primary care and particularly in the pediatrics, we would oftentimes discover first episode psychosis that really had gotten sort of unrecognized and got recognized as part of primary care. Bipolar, going to talk quite a bit about bipolar, suicide risk or danger to others, self-injury, substance use. There's a couple other diagnoses that sort of fall under this bucket, but a couple that we might talk about a little bit. And when I think about suicide and addiction or substance misuse, I kind of think about it across that entire spectrum or that entire umbrella grid because you're going to get people at different levels of risk. You're going to get different people at different levels of use, and you're going to get people across the spectrum. So really, even though we're going to talk some about alcohol or substance misuse today, they kind of span the spectrum. You're going to see them in all of the categories. So, a couple of things to start us thinking about, and all of you probably live this every day. A lot of folks are going to consider primary care and our health centers their behavioral homes, their clinical homes. So maybe they should be in care someplace else. Maybe there is more appropriate or specialized care, but we are where they come and we are their clinical home for lots of different reasons. Sometimes there's no services available. Sometimes they're not able to go to those services. They're not accessible. They don't want to, whatever the case may be. Also, we get individuals who have serious mental health conditions because they need primary care. right? So they may be getting specialized services someplace else, but they're coming for primary care or they're coming for some of our services. So even if we have behavioral health services, we may or may not be treating them, or maybe we are, but they're still getting primary care, they're getting comprehensive care. And also, the reality is that we have not improved the mortality rates. I remember when I first started doing integrated care work, I don't even want to say how long, but decades. And we would talk about how individuals with serious mental health conditions were dying 25 years sooner than the general population from chronic illnesses. And we haven't actually moved that needle much in all of the years that we've been doing integrated care. We still have much higher mortality rates in this population. So something to really think about because we know those are fixable problems. It's care. So going to start by a little bit asking some hard questions and giving you some things to think about. And so, one of the things I remember being in a residency program and asking, so if someone comes in and they have bipolar and they have diabetes, what do we do differently? What does it look like? And so, how do we deliver services differently for them? And no one could answer that question. And I think that's a really hard question. And I think it's a question that people really need to answer in their organizations. What is it that we do differently? And what are the experience of people accessing our services? So what does it look like for individuals coming in with a serious mental illness? What is their experience in accessing both primary care and behavioral health services from our organizations? And then what about our providers? So in sort of preparation for doing this, I was in a community health center and I asked some of the behavioral health folks and I said, what do you do something, particular for individuals with serious, mental illness or, with some of the more acute diagnoses? And they said, we haven't really thought about it. They kind of come in and we give them appointments like we do everyone else and we treat them. And I thought, it's interesting, like, how are we successful? Should we be doing something different? What does that look like? I think that's an incredible issue. And understanding how some of these services are delivered is really, and thinking about the experience of patients is really going to help us understand some of the disparities and also engage some people in care. So, a couple things that I wanted to just point out because I think we need to start to really think about them. So, some of the considerations that we really want to think about is some of the polypharmacy and just the number of medications that people might be on. So, for example, bipolar patients often have some fairly complicated medications, right? Some of our friends who have, psychotic disorders might have some pretty complicated medications. And so, are we doing anything different for them? Are we talking about medication support? Are we talking to them initially about pill boxes or support around medications or things that they might be able to do, reminders, putting things on their phone, all of those considerations? So, something that we really need to do differently. Have we really thought about the lab monitoring? So not only, our folks with bipolar and others that are on medications that need constant or frequent, rather, lab checks. Most of the individuals in this category actually do need labs drawn more consistently because of the medications. So, do we have a plan to do that? And so, I was talking to the behavioral health folks the other day in the health center, and I mentioned this to them, and they said, actually, you know what? We should probably think about that because our psychiatry providers oftentimes aren't requesting the labs or, they're trying to get copies of the labs. Maybe we should be doing the labs. So really something to think about. And when we engage someone in care, it's kind of like you engage them in care, and on that first day when you're really doing care planning with them, are you really doing care planning around medications and labs as well? So how difficult is it for you to be able to come in for the lab visits as well? Could we combine those with other visits? What does that look like? Do they have to go someplace else to get labs, and are they going to need a little bit of support to do that? And also suicide risk, individuals who are more at risk for suicide. I remember I did a project one time in my own organization some years back, large federally qualified health center system. And we had really started to track the number of people that had died by suicide. And what we found is that more people had attempts to die by suicide or died by suicide in primary care versus behavioral health, and that there was a pretty significant percentage of them that were bipolar. And so this was a surprise to our primary care providers because they didn't actually think that more of the suicides were going to occur on the primary care side. And so what are we doing? Are we asking people about suicide? Are we screening very specifically around suicide? So we have learned more and more that the PHQ-9 is actually not a great question for suicide. Question 9 is not actually a great tool. And so people are starting to ask specifically about suicide with the ages and stages. Oh, geez. With the ASQ, rather, not the ages and stages. We're not talking about early childhood. With the ASQ or with the Columbia scale, and actually screening for suicide very specifically. And so this is something that you might want to do maybe with these individuals. You automatically ask a suicide question after the PHQ-9 if that's part of the process. But again, doing something different. So these individuals are way more at risk for comorbidities. So whether we're providing primary care to them or behavioral health services, what are we doing around that high risk for comorbidities? What am I doing differently in my behavioral health treatment that I'm taking this into consideration? So am I providing education and information? Am I making an extra effort to make sure that someone is connected and really engaged with primary care? What does that actually look like? And it should be part of my care plan, right? It should definitely be a consideration that is somewhere in my documentation. Sometimes also we're really seeing individuals where it's really hard to sort of tease out some of the symptoms and maybe do a differential. So really thinking about and maybe doing some case presentations or some learning around individuals. I know that I was working with some students the other day and I asked them about the difference in some of the bipolar diagnoses, and they weren't aware. And so really maybe doing some education. Oftentimes, we spend a lot of time thinking about differentials and specifics for some of the more common diagnoses, but are we really familiar with schizoaffective, with bipolar? Could we really do a solid differential there? And also, a lot of social support and some lifestyle. Oftentimes, individuals will really have difficulty sleeping. Sleep is a huge problem, also is a huge risk factor for suicide. We've seen more and more. Also affects medication, right? So we really want to make sure that we're taking some of these pieces into consideration. And if we're not providing the behavioral health services, then we're addressing some of these in the care with individuals. So there are some new additions that HHS actually put out. There are some new federal guidelines that really talk about shared decision making, informed consent, and also putting in some practices. So a lot of these individuals will be on quite a few meds, as I mentioned. Do you have a process where after, 10 medications that someone gets reviewed? Do you have something where, 6 months someone is sitting down with this individual and really going through the medications? Really understanding why they're taking the medications, what that looks like. The CARE Act integration or the eligibility is there's a whole guidance document around referrals for primary care providers. So these are two things that are kind of new. I'm not sure that you're going to find them particularly helpful. However, I really wanted to call them out here because you may hear about them. You may want to know a little bit more about them. And they are new and they are out there. So one of the things that I've really seen play out over the years is scheduling. And these scheduling considerations are really, really huge. And so one of the things I know that I have done with organizations is actually look at when people are not keeping appointments. So I did something recently and we looked at it in the calendar and we looked at no-shows and we looked at cancellations and we looked at them by diagnoses. And you could actually see that people with anxiety were less likely to come in later in the day, which I thought was kind of interesting, but makes sense to me. And so looking at your population of people who aren't coming in, but folks that fall into this bucket, right, do have a higher rate of no-shows. And so when we think about that, how do we want to accommodate, right? How do we want to try to engage people and how do we want to accommodate? So I know particularly that some of the research shows around morning times. I used to like to, in a prior life when I was running behavioral health centers, I used to like to bring these individuals in the morning, and that would be for a couple of reasons. One, because if they had some low frustration tolerance, then you could have people come in and out. Oftentimes it was quieter, and so it was less impactful for them in terms of it being a little less chaotic, not as noisy, not as distracting, not as overwhelming for people. So morning was actually really helpful for them. And also a lot of times, you can like physically people are at different points in their day when morning tends to work out a little bit better. So I might encourage you to think about being intentional about when you are scheduling individuals. So just give you something to think about. And certainly, the cortisol levels being a little bit lower. So wanting to take advantage of some of those pieces as well. So sometimes when you're thinking about scheduling, there are folks who you want to try to schedule. Maybe they have transportation, arranged for them and they come in and you want to try to do some of the early mornings. However, you also want to have some open access times. So for these individuals, it's super important to have some open access scheduling. So maybe you schedule 2 mornings a week or 3 mornings a week, and then 2 mornings are times when you just get individuals and they can just walk in. And those walk-in services are really helpful. And if you don't have any open access, then that's something to really think about because it does give people options. And so many times, if individuals are having difficulty sleeping, it's very hard for them to be able to get up and moving. Then maybe those are the folks that you're bringing in right after lunch. And again, maybe they're the first ones in after lunch. So in other words, they're not waiting, and then you reduce any sort of anxiety ability. And so that's incredibly helpful. The other piece is for individuals with these diagnoses, one of the things that you're working with on is a structure, having a daily routine, getting up, getting out of bed, having some activities. And so putting individuals in morning appointments can often be helpful and really facilitate that, and can actually be part of their care. So what we might want to do too is actually have a very intentional conversation with people about what time of the day is going to be good for them. And so for those folks who maybe are going to have some medication side effects, they're going to be a little bit groggier in the morning. Maybe some of the individuals who are older actually might want to be a little bit earlier in the day as well, because by the time they get to the end of the day, they might be a little bit overwhelmed, something called sundowning, where they might be having a little bit of cognitive decline. And so have the conversations. When is a good time of day for you? But even just thinking about some of these considerations around scheduling. I know that one of the things that we talked about recently with a health center is that they move their administrative time and some of their meetings to the end of the day because that was less beneficial for a lot of their patients. And that's when they were having a lot of the no-shows. And so they figured it was better to capitalize on some of the mornings for exactly these reasons and move some of their other time to the afternoon. So we've just spent some time talking about no-shows that are a lot higher in this population. Also, and just kind of putting this out there, a lot of times it is really hard to be able to work with individuals sort of in individual treatment. A lot like bipolar is really around medications and supporting someone on medications. What I have found is that there are some evidence-based practices that work really, really well in community health centers and community settings. And I actually think groups are wonderful, and groups can be really helpful for a couple of reasons. One is because then you don't have individuals missing appointments that leave you with an open slot, affect your operations, affect access for other individuals. And also, they get the benefit of having that group experience, and you get the benefit of running a group and not just doing individual care. And what I used to do with evidence-based practices like wellness self-management. So wellness self-management is a really, really cool model, and it was meant to be given over the course of a year, which in primary care and behavioral health, like those integrated settings, doesn't necessarily work. So what I did is I actually combined it. I doubled the session and I had it be 26 weeks. And the way that we did it is where you came in is where you got off so that you would stay in it for that period of time. Or it was just run ongoing and maybe people always didn't make every session, although we had a lot of people that had much higher show rates than they did with individual sessions. But wellness self-management, and we'll put a link out when we share the slides, actually has really nice workbooks. People can come and it takes people through health, quality of life, vocation, all different categories. And it is really, really helpful for individuals. And so it gives you the ability to really provide evidence-based treatment to this population. And oftentimes they don't get it or they don't come consistently to get it. So this is actually a really good option. This illness management and recovery, or IMR, also another curriculum-based approach around setting recovery goals and following up. I have found these groups to be incredibly helpful for individuals and to run them as treatment. And they would attend the groups, they wouldn't come to individual sessions, and you could bill it as a group. That 90853 code is often really helpful. So we'll send information out about these. They're not hard groups to run. They're actually pretty easy and fun to run, and they're incredibly helpful for people that fall into this population. Also, really encouraging you to think about very specialized treatment. So, there are tools and ways now to monitor individuals with bipolar, as an example. So, we're going to use the city to help identify people with bipolar. There are really a couple of tools. Most used to use what was called the MDQ to sort of identify individuals with bipolar. Now folks tend to use the city. It's just a little bit more research based. But when you think about bipolar, you want to say, well, how are we treating this population? How are we caring for them? What are we doing? And I remember being a behavioral health director, and I know Rick just talked about the event on the 29th, but these are some of the, I'm going to say, the challenges that we take on in those leadership forums. Like, how do I care for populations of patients? And so I remember thinking, like, how are we caring for bipolar patients? Like, what do we do? How do we know we're successful? What evidence-based practices are we using? And so really started to think about it. And what I realized is that we weren't doing a great job of engaging many individuals who had bipolar. So started to think about it a little bit differently, and the wellness self-management went really well for folks. Did also the CDC medication survey so that we could really support people around their medications. And then using the PMQ, which is the Patient Mania Questionnaire, which some of you might not be familiar with, alongside the PMQ, right? So the depression and the mania, sort of monitoring those ups and downs, really allowed us to look at very specific symptoms and to track people in order to help them get better and to address those daily symptoms that they were experiencing. So what it did, it gave us a little bit of structure to the care of individuals with bipolar, that there were outcomes that behavioral health knew, that primary care knew, that patients knew, and it worked out a lot better. And also for trauma, using the PCL, individuals who have a pretty significant history of trauma, and using the PCL is really helpful to both identify and care for individuals so that you're putting some structure there for the treatment. And it's important to start to think about pathways. And pathways are very different than workflows. Workflows are kind of like who's going to do what when, whereas a pathway is like, what does good care look like? Like, I like to put people in a room and say, if we were going to do amazing care, excellent care for people at risk for bipolar or that have bipolar in our system, like what would we do? What would we give them? How would we care for them? What would it look like? And that's really how you get a pathway in your organization. And so when we think about pathways, how are we going to identify people who have a serious mental illness, right? Are we going to use the city to help identify bipolar? Are we going to ask some questions about, history for some of the other diagnoses, right? And then how are we going to treat them? How are we going to know we're successful? What does that look like? And so we can certainly share these pathways, but super helpful to start to think about what a pathway looks like in your organization. So that if I'm in your organization, whether I'm in behavioral health or primary care, I'm like, oh, I know what to do. This is how we care for someone who's at risk with for bipolar or has bipolar. So one of the pieces that come up, and I know some of you might have been in on our suicide care trainings, it is incredibly important to start to think about individuals who have a serious behavioral health diagnosis that may be suicide risk in and of itself. Because if someone is at risk for suicide, then we want to make sure that is the primary diagnosis. We want to put that code on our problem list, right? That's what we're treating. And so we need to start to think about our population of patients that are at risk for suicide in different levels. And so many of you use the Columbia scale, and we talk about having individuals that are lower risk, yellow, that are sort of in the middle, that are orange risk, and individuals that are high risk or red. And for those individuals that are high risk or red, I would put those on the more serious or acute sort of part of our grid and the population that we're talking about today. And what really distinguishes them is intent, right? That I intend to die by suicide, right? I have the thoughts, but I definitely will not do anything about them, right? So I'm going to act on them. I've had some intention of acting on them. And so when we think about individuals that are in the serious side of behavioral health conditions, we're thinking about the individuals that are read here that have some intent. And I would actually divide them up into two buckets. So one is that some individuals who are at high risk for suicide may need a safe place to be. That is a very small percentage, but there are some. So they are individuals that might need to go to an emergency room or to a hospital. Again, that is a very small percentage of individuals. However, there is another category that is high risk because the individuals who are high risk, who have some intent, but we're not going to send to the emergency room, or who go to the emergency room or the hospital and then come back to us, they are still high risk, right? And they are going to stay high risk for a period of time, but we're still going to care for them. So we're going to consider those folks on our higher, more acute side of our umbrella grid over there. And we're going to put some systems in place for them. And we're going to say, hey, we're going to make sure that we see you every 7 days. We're going to make sure that we're checking your safety plans. We're going to make sure that we ask you if you're safe every time. So all of those pieces. So again, individuals who are at risk for suicide would definitely be on that sort of higher acuity end. Many organizations are also using this Columbia scale and modifying it for danger to others. And so individuals that are at risk for harming someone else. So do I have the thoughts and do I intend to act on them? So you could put individuals in that category, sort of on this spectrum as well. So for some of the lower folks, you're going to be doing some very basic safety planning, and making sure that they have some of the resources that are out there, your lifeline, and your Now Matters Now. So we're giving people that are not sort of on that acute spectrum some resources and things that they'll be able to use, for them. And then for individuals who are very high risk, so individuals that are definitely on the serious and more acute side, particularly at risk for themselves or someone else, I actually like to bring out this emotional fire safety plan because one of the things, if you remember when you were young, you learned to stop, drop, and roll if you caught on fire. They didn't tell you to dial 911 right away because you're on fire. You can't, right? You have to do something to put the fire out a little bit. And so this emotional fire safety plan, I thought I would share it today. We usually talk about it when we're talking about suicide, but since we're talking about sort of more acute patients here, I added it in because it's important to let people know, hey, like if you catch on emotional fire or if you catch on physical fire, you know what to do. You stop, drop, and roll. I want you to know what to do if you catch on emotional fire. And this is really helpful for individuals that are in danger to themselves, to someone else, and even some individuals that are on the acute side that are maybe cutting or are self-injurious behavior, right? So that they have an emergency plan. They have this emotional fire safety plan should they catch on emotional fire. And there are a lot of things on here. They're very basic DBT skills, but things that can be imminently helpful for them. And so the ability to splash cold water on my face, right? That cold water is going to physiologically be helpful for me. I'm going to look in someone's eyes on my phone or in person. And also, if I stop, drop, and roll, what am I not doing, right? I'm not dying by suicide. And so these are really important things. And so if you have individuals that are sort of on that higher acute level, then certainly can do that. So I wanted to just stop for a moment because oftentimes we get a lot of questions around sort of the suicide risk or managing some of these individuals. So I wanted to just stop for a moment and ask questions and see if anyone had a question here. And I can take this one as well. Share how you incorporate treatment team meetings in managing patients with behavioral health conditions. So I think it depends on the different treatment team meetings. Actually, in the morning huddles, like if you're an organization that has those morning huddles, I like to bring up individuals that are coming in and saying, hey, we have someone coming in and they're, bipolar, or this individual, was really having some command hallucinations last time we saw them. This person was potentially, at pretty high risk for suicide. We still have them on high risk. And so that people know and we can talk about what to do a little bit differently for them. And so that would be, and also team meetings. So if you're going to have a team meeting around these individuals, you likely could even bill for that time because they're probably going to be pretty comprehensive conversations. But I would think that I would prioritize these individuals for those team meetings. And so I'm not quite sure, Lynette, if that answered your question. But I wouldn't say all behavioral health conditions, but I would say the folks that we're talking about today for certain. If you're going to do any team meeting activities, these are the folks you probably want to bring up and talk about. So let me know, Lynette, if we didn't get that quite right. And then there's a question around, um, no, not everybody does need a full safety plan. You can actually do this safety plan for individuals who are high risk. It does not need to be the full safety plan. So I could do this for someone at high risk, and then maybe I do another full safety plan, or what you're probably be referring to as the Stanley and Brown safety plan, that sort of more comprehensive safety plan. But you would be able to do this one. So thinking about quality improvement, and one really nice way to be able to fold individuals with sort of these serious conditions into care and getting people to really understand is again doing what we talked about, the times of the day, right? So going back and looking and pulling, one time I pulled all of the patients who were bipolar, and I looked at all the appointments that they had missed. What percentage of appointments were they missing? And then what times of the day were they missing them? And that was incredibly helpful. Like I had never thought to pull that information, but if you ran that report in your system now, it would really be incredibly informative. And you probably would change how you schedule and maybe even change how you're delivering care. Um, and it also really tells you about engagement. I learned that we actually weren't doing a really good job of engaging people, that we lost a lot of people, and the ones that we were keeping were coming for medications, but that was really sporadic. And then they would drop off for a period of time and then come back. And so we weren't actually keeping them consistently in care. And so started to really think about what that looks like. And one of the things that I stopped doing was stop saying you have to come in for behavioral health sessions, because that just wasn't working. And so what did work was then to have a group that they could come in, and I would, they could just drop in and come to that group. And that was actually very helpful. The other is to think about doing some quality improvement projects. So, for example, individuals around preventive care. So if I looked at all of the individuals who hadn't kept their women's health preventative appointments, right? And I looked in the records or did a deep dive, I would find that a large majority of them probably have a significant history of trauma, or that a lot of individuals might fall into this serious behavioral health condition. And so what does that mean? So that kind of plays right into the 25-year mortality. So what are we going to do differently? And so one thing that we did was we actually had a peer accompany people to some of those preventive health visits. The other thing that we did was we did an education session. So when we were doing the wellness self-management, we actually did a whole session on preventive health. And we had a lot of women, and we talked to them about what a PAP was and why you do it and what happens. And we had a provider come, and we had the provider talk to everyone. And so what we were able to do is really work with a lot of those individuals to be able to get some of the preventive health measures. But a large majority of individuals that were on my list of not meeting or getting those preventive health were individuals that crosswalked. And so we did a quality improvement study there. And then we also gave language to providers so that if they looked and it was someone who had a serious, behavioral health condition, we gave them some language to use, to talk to someone or to let them know what was going to happen, or ask them if they would like company. And so what we found is, again, we doubled the number of people that had got those preventive health measures. So giving you something to think about, and some really good projects to be able to do. So I think it's helpful to go back and to sit in that team meeting and say, what would good care look like, right? So what would be the ideal modalities? Are we going to run groups and use, wellness self-management and the illness recovery? And if not, what are we going to do? What very specific modalities are we going to do? And what are some of those key considerations? Are we going to really think about scheduling? I strongly encourage you to think about scheduling. And I strongly encourage you to pick a diagnosis and to just, run a report and then involve everybody. If you do a quality project, so if you ran a report and you saw that you had, 200 bipolar patients in your practice to really, or in your organization, and then look at now a lot of the EMRs have like they can tell you the percentage of appointments that have been missed. Where does that rank for all of them? Do they all fall into that bucket? What are some of those times? And then if you share that data out with the team, that's really helpful because they're not just missing, behavioral health appointments, it's primary care, it's dental. And so if everybody in your organization has that information, then they're going to be, and maybe you put like morning appointment or something, in their chart so that you would be able to do that. And then how would training be different? If I come into your organization, what are you going to do differently for me? For someone with a serious behavioral health condition, what different training would I get? What considerations? What would I know? And then how are we going to know we're successful? So I was thinking, well, how am I going to know if I'm doing really, really good care for the individuals in our organization that have bipolar? How am I going to know I'm successful? What would it look like? So what did I see? I saw people engage more in care because they were coming in more. They were completing treatment more, right? We weren't losing them. They were having good outcomes on the CDC medication survey, where you can sort of track some of that adherence over time. And they also were not going to the emergency room or the hospital as much. And so I had the ability to kind of look at that as well. And so then I was like, those are sort of the ways that I'm going to manage or that I'm going to know that I'm successful. And so I really encourage you to think about what does that look like? How do we know? How are we going to track it? Um, and then be able to ask if someone comes in and they're schizoaffective, like what do we do differently? How do we care for them? What does it look like? So I want to take a moment. Usually we have a ton of Q&A for these, so I wanted to give a couple of minutes for folks to just ask some questions and maybe hear from folks around what you're doing in your organizations or what you think might be helpful. So we'll give it a minute. If you're feeling shy, you can send it to me directly. And if you're feeling brave, you can unmute or you can put it in the chat. Let me pull the questions up in the chat here. Yeah, a patient advocate. So the patient advocates are super helpful. And also the patient advocates a lot of times are the ones that could go to the preventive health appointments or the ability. And what I will do sometimes with patients at risk that I'm going to worry about is to say, if you don't come in, I would like for you to meet Rick. And Rick is the person that's going to be going out to the house, or Rick is the person that's going to be working with you. And so the patient advocates are incredibly helpful, particularly for pre-visit planning. And then they also know too what times a day might be good for people or not good for people. So yeah, the advocates are really helpful. Engage them right from the beginning if you're lucky enough to have them. Oh, yes. So there is no special training to do the wellness self-management. There is a workbook, a curriculum. So there's a guide for facilitators, and then there's a workbook for individuals, and it has the information to order them. I think you can also print them out now. They are pretty readily available. One of the things that I found is you just had to keep running the group. Like you couldn't stop it and start it. Like I would just keep it running continuously, and then people knew every Thursday at 2, or, in the morning and do it. And it got to the point where, we were running it 2 or 3 times so that people would have different options. But no, you don't, there's no like certification. You can just get the information and we'll make sure that we share it out so that you have it. It is a lot of fun to run that group. So, would you highlight any specific case studies of significant organizational improvement? Yeah, I have absolutely seen the preventive health measures. One time we doubled the number of women that got PAPs, and then providers had language that they could use. So, absolutely, we've seen it around the preventive health measures. We've also seen it around some of the like the colonoscopies, the flu shots. I think we've tried pretty much all of the measures at this point and always had really good outcomes. But I think the important thing is that I had to understand as a behavioral health provider that that was also part of my role for this population, right? That I had a relationship with them. They were, I was caring for them. And I needed to have the discussions, to really help facilitate them to get some of that preventive care. And also part of the wellness self-management group, we actually, and I've seen it woven in where people will ask, what preventive care don't I have, right? That I need, and they would bring it to the group. And so we would talk about it and we would answer questions and we would have a provider there. And so that I can't tell you how valuable that was and how engaged people were. Many of them didn't even understand what some of the preventive health measures were. No one had ever really explained it, and they could ask questions. And then they had a list and they were able to, to check off the list, and it was part of what they were doing in group. It was super valuable, super fun, and changed the trajectory of them getting, things. Thank you for sharing the best time to see clients. I would mostly see them in the afternoon because they tend to sleep late. Yeah, but that's a really important piece. And for some people, that's true. And for others, the mornings are going to work better. I know for some, when we had a large group of patients that had psychotic disorders, we would have them come in the morning. It was good for their routines. There weren't many people in the practice. They could kind of come in and out. People had a little bit more time to spend with them. So that was actually really helpful. Well, thank you. It is always a pleasure to be able to have these conversations, and particularly if we have primary care providers here, to really think about what you do differently and some of the considerations is super helpful. I am going to put a huge plug in for the event we have on July 29th. I have heard over and over again for behavioral health leaders that it is incredibly invaluable for them. And this year we are going to spend time talking about going from a clinician to a leader. We're going to talk about, we have a huge deep dive in pediatrics. So everything you wanted to know about running pediatric clinical care, from tools to outcomes, sort of ask the experts. So we have some pretty good in-depth topics like that. We're going to be doing a deep dive into collaborative care. We're going to be doing geriatrics. We're going to learn about some new billing codes and how to optimize them. We're going to be asking some questions around scheduling and giving some hands-on help for people to optimize their schedules. So really looking at some of those things. So strongly encourage you to come and join us in DC. Well, thank you, Rick. I'm going to turn it over to you. Is there anything you'd like to say in closing today?
Absolutely. So first, I would echo, please don't hesitate to apply for our behavioral health scholarships. As Verna mentioned, this really has been a standout event for our community, and we really have a pretty diverse mixture of attendees. It's both direct clinicians at FQHCs, and it's also those working at PCAs to increase capacity in this area too, across an entire network. So we really welcome a diversity of voices, and we hope you'll, whether or not you fit into either of those categories, we really hope you'll apply. Also, I should mention that though this is the concluding webinar in our current series, we will be offering a variety of trainings and opportunities for technical assistance in this area. And we encourage you to contact us, whether we can help directly or facilitate connections in this area. We're really happy to. Lastly, one thing that Verna had mentioned specifically earlier was some of our work in suicide safer care. Via our support from the Centene Corporation, we're able to offer some pretty robust trainings and resources here. And these really focus on both enhancing primary care teams' toolboxes with practical suicide prevention strategies, as well as ways to really transform the culture of practice and prevention at an organizational level as well. So we encourage you to learn more about that on our website too, under our Suicide Safer Care page. And with that, I think I'll thank everyone for joining us today, for attending our webinar and joining us for our series as we conclude today. I hope everyone has a wonderful day. And thank you again, Dr. Little.
Thank you. Have a great day.